but I'm super excited to have you on because
Thank you.
not only you're an awesome sports medicine surgeon, but you're also a good friend of mine for a few years now. Our executive producer is Donis Gill is here, and then we have my co-host is Rob Shapiro. Rob, this is Dr. Alexander Golant. He is an NYU orthopedic sports medicine surgeon. When do you see patients, Dr. Golant? Every day, all day, or?
No, I got to operate sometime. I see patients usually 2 to 3 times a week in Brooklyn in 2 locations and in Manhattan. Manhattan's down on Wall Street for now, and in Brooklyn it's Cobble Hill, which is downtown, and then Bay Ridge for now.
Yeah. Good deal. And I asked you to choose an article about the complex patellofemoral pain patient because I know that you had sent me somebody that had multiple procedures in the one knee, and I found that very interesting and very complex and very enlightening too. So why don't we just get started by talking about the anatomy of the patellofemoral joint?
First of all, was it my patient, and hopefully they did well?
They did well. She's back playing tennis. Yes.
Amazing. She didn't know how to play tennis before, so you did a good job, Tim.
Well, I get out there volleying, and hitting some ground strokes.
So first of all, Tim was one of my mentors when I was in fellowship. He taught me all things rehab and physical therapy, and opened my eyes to the importance of it. Because when you're an orthopedic resident, you hear it, from your attendings. Oh, therapy is important, but when you're a fellow and you start looking into it in a little more detail, and I did my fellowship at Atlantic Sales, so Tim was one of our educators. I learned a lot. So I specialize in knees and shoulders and a little bit in elbows, but primarily knees and shoulders, probably to the tune of about 60-40, with a preference to the knees. And in the knee, one of my areas of interest is patellofemoral joint. Patellofemoral joint is it's kind of like the back pain of knee surgery. Nobody in sports medicine wants to deal with it. They're like, oh God, patellofemoral pain, patellofemoral issues. And that's probably because patellofemoral issues can be tricky. They can be tough to pinpoint. There's a lot of misunderstanding. There's a lot of confusion, and there's not a whole deal of agreement. With other sports things, we kind of have some degree of consensus. We may disagree on the graft option for ACL. Some people like BTB. Some people like hamstring. Somebody likes a quad. But by and large, we agree that young athletic people with ACL tears need to have their knees reconstructed. Although now there's a little more controversy with ACL repairs. But for patellofemoral instability, patellofemoral maltracking, and other similar conditions, there's just not a whole lot of agreement. And so people don't like it. I tend to like it. I like complex things. And so I do get these patients who need not 1, but 2, 3, sometimes 4 procedures. And you need to look a little bit past the simple algorithmic stuff. So that's why, you asked me what I wanted to talk about, and you suggested multi-leg knees. Multi-leg knees are very interesting, but kind of more rare, I think, for a physical therapist. And I think this meeting is geared heavily towards people in the PT world, ATC world. I think it's not going to be super common unless you're covering, county hospital in Chicago or Jamaica and Queens or something like that. You're going to see a ton of multi-legs. But you are going to see pretty much anywhere you are a whole lot of patellofemoral pain and patellofemoral pathology. So I thought this would be a much more interesting topic for us to deal with. Hence the article. The article is kind of on the more esoteric side, but sort of a little bit almost exactly of what I do. And we are actually publishing our own paper soon on the exact same thing, just a slightly different variation.
Outstanding. So we're not talking about patella instability, which is pretty different than patellofemoral pain syndrome, are we? Which more the patient who comes to you for pain, or it's the one that dislocates and has chronic dislocations. Tell us about it.
Yeah. So first of all, if some of my older mentors would take a lot of umbrage with the words patellofemoral syndrome, there's a lot of folks who I learned from who say there's no such thing as patellofemoral syndrome, because by definition, syndrome contains certain very specific things. You have Down syndrome, which contains certain very specific ways we can diagnose it, Cushingoid syndrome, and so stuff like that. Patellofemoral syndrome is kind of an umbrella term for all things that are bothering people in the anterior knee that are maybe not, like you said, discrete patellofemoral dislocations. But there's really a spectrum, and in the instability world, there's a spectrum too. You have full-on dislocations, you have subluxations, and then you have something that I think is like this, instability adjacent. You have patellofemoral maltracking, and I think patellofemoral pain, or patellofemoral, what people refer to as patellofemoral syndrome, kind of spills from the realm of just pain in the anterior knee and patellofemoral joint due to sometimes just overload, compression, but most likely there's some degree of maltracking. So I don't like to use the term patellofemoral syndrome, maybe because it's kind of been beaten into me and ingrained in my head that there's no such thing, although it's a diagnosis that I pick on my electronic medical chart because that's how it's listed. So if I don't have a specific diagnosis of instability, I'll say patellofemoral pain syndrome, and then I will kind of specify. But patella maltracking, if I don't have overt instability, then patellofemoral maltracking is my next most common diagnosis.
Is there always maltracking in someone with patellofemoral pain?
No, not always, but a lot. I think, and a lot of times there's some degree of maltracking, either dynamic or static or combination thereof. But I think, obviously you can have patellofemoral pain from cartilage disorder, right? Just degeneration, age-related, sports-related, previous injury, and so on and so forth. Mm-hmm. But in absence of damage to the cartilage in an otherwise healthy knee, if you're looking at an imaging study and you don't see structural damage and they have pain, it's usually due to some degree of maltracking. We call it sometimes lateral compression syndrome, where the lateral facet of the patella makes up.
Oh, we don't use lateral compression syndrome.
Yes, thank you. Yes, very good, very good.
Yeah, you taught me something.
Yeah, I taught you something. So right back at you. But yes, so lateral patella compression. Okay. Sometimes you get kind of less common things, but in certain patient populations like Hoffa's pad impingement, you'll get in dancers and other people who do a lot of very deep flexion activities, spend time on their knees, like sort of wrestlers may get it without actual maltracking. But I do think that maltracking is present more and sees us more than we see it.
And who gets that? What's the epidemiology of that? Who gets that maltracking?
Yeah, everyone gets it, but right. The most common people we see it in will be the younger population, teens, 20s, 30s, possibly because by the time you're seeing folks in their 40s and 50s, if they had some maltracking or abnormal tracking, if you will, at this point you might be seeing the downstream effects. So you might be seeing cartilage wear and arthritis, chondromalacia, mm-hmm. and such. So you may not call it maltracking, and we may be calling in the literature just patellofemoral arthritis. But a lot of times when I do knee replacements too. So a lot of times when I'm doing a patient that I'm doing a knee arthroplasty on, either patellofemoral arthroplasty or total arthroplasty, and I'll look at their patellofemoral joint, you see that abnormal tilt, and you see that typically, you almost never see excessive medial wear relative to the lateral side, except in rare cases. But typically the patients that present with pain without significant structural damage and that lead me to that diagnosis will be in their younger age, and more commonly female due to certain anatomic variants. Do you find that people with a high bending score or loose ligaments are more susceptible to patellofemoral issues, or no? I haven't found that to be the case in my practice, and anecdotally at least. And I haven't seen that in the literature, Tim. Maybe there are such reports. Certainly, people with you're referring to folks who have generalized ligamentous laxity and have a high Baton score, 0 to 9. So anything over 6 is considered really bad. When I see folks with patellar instability, I will always check for and really any instability, ACL tears, shoulder instability. You got to check the Baton score because it can lead you to do some additional things when you're doing surgical procedures to stabilize them. So in patellar instability patients, that may be one of the factors, but straight maltracking, not necessarily. Or at least I haven't seen it.
Okay. A patient comes in with symptoms, pain up and down the stairs, prolonged sitting, deep knee flexion. Any other? Those are the ones that we know of as physical therapists. Any other complaints that really sets off a testing for patellofemoral pain? How do you make the diagnosis in your office once the patient comes through the doors?
Yeah, I mean, like you said, it's that going from sit to stand pain, or going up downstairs, down sometimes more than up, because we know patellofemoral joint gets loaded heavier when folks go downstairs. Uh, Getting up from kneeling or difficulty kneeling, all of that is our potential complaints. In terms of how I make the diagnosis, my favorite exam, whether or not symptoms are coming from patellofemoral joint versus not, is whether the pain is reproduced with more active range of motion rather than passive. So if I have the patient lying down and I take their knee and I tell them to relax, and it can be difficult to relax a patient's knee, and I take it through a gentle range of motion. If they don't have a lot of arthritic changes in the patellofemoral joint, they're usually not going to feel a lot of pain if I'm just gently gliding them. It's kind of like doing a CPM, a continuous passive motion machine, which we know we use after surgery all the time when we do work in the patellofemoral joint, cartilage work, etc. Why? Because it doesn't create joint reactive forces. It just gently ranges the joint. On the other hand, I'll have the patient, I'll say, hold your leg up and now arrange the knee the same way I just did. And when they do that, especially as they're bringing it from flexion towards extension in that 20, 30, 40-degree range, they're going to say, that hurts. So right in that point, their patella is engaging their trochlear, and they're firing their quads, they're firing their hamstrings, so they're co-contracting, and they're creating joint reactive forces. So they're compressing the patella in the joint. So if they're having pain right around that time, that is an indicator to me that the pain is coming from the patellofemoral joint. And then, we can get into more details of what kind of exams I look for in terms of stability of the patella versus just maltracking.
Gotcha. Rob, any question on diagnosis that you have for Dr. Golant?
Not for now. I know we're going to do special tests and stuff, so I'll wait for that. Yep.
Good.
All good.
Rob's old like me, so he probably remembers deep knee bending as a movie house knee.
That's what I was going to
movie house, theater goers knee.
Theater goer sign. Yeah.
Yeah. So
no, for sure. That's I think I still hear that called that sometimes, but I don't know what it would be called now. Sitting on your phone on Instagram goer sign.
We'll rename it.
Yeah.
Let's get into the special tests. Let's get into. I mean, in the old days, we're doing patella grind, apprehension, things of that sort of nature. What do you use any of them? Is there anything useful that for us, either in the training room or in the clinic?
Yeah, I gotta be honest with you. Apprehension patella grind is really only going to be painful when you have some acute and significant pathology. And you got to put the patella into the articulation, right? Because in full extension, the patella is sitting proximal to the trochlear, so it's not articulating there. So if you have something right on the median ridge of the patella and you're rubbing it against the femur, that's going to hurt. But it's got to be kind of acute and significant. Usually, you're not going to get a lot of symptoms out of the grind. Even in folks with arthritis, I don't often get it. I always test for apprehension if it's a patellofemoral complaint. And the thing I look for a lot is the J sign. The J sign, if you're looking down at your leg, basically on your left knee would be reproducing the letter J, and your right knee would be the opposite of the letter J, kind of flipped around, mirror image. So that's basically the patella exiting the trochlear and making a little bit of
It's a J when it goes from flexion to extension or extension to flexion?
It's from flexion into extension. So it says your quads contract as you extend the knee. But you can see it from either one. You just basically, so it would be it's whichever way you draw the J, whether you draw the J from up into the, loop or whether from the loop and then goes up like that. So I guess that wouldn't necessarily be a J, but you're looking down at your knee, it makes the J pattern. When you're looking down at your left knee, it's the J pattern. When you're looking at your right knee, it's the mirror image of the J pattern. So the J sign is a big indicator of maltracking, right? So I get folks without instability, but with a J sign, we kind of, some people grade it 1, 2, 3. Some people just call it mild, moderate, severe. There's a jumping J sign, which is where you actually see this kind of a jump. I don't know if you've ever. I'm sure you've seen it.
I have seen it. It kind of pops back into the groove.
Yeah, it's pretty crazy, right? So there's the concept of a ski ramp, and we'll get to talking about the trochlear dysplasia, but in severe cases where you have a bump or a spur, and the patella hits it like a ramp, and then like a ski jump, and it hits a ski jump, and then kind of lands into the groove eventually. Because even with severe trochlear dysplasia, most of us have a groove further down, but proximally when we don't, that's when this thing happens. And it can be painful and disconcerting to a patient to the point that people don't want to move their knee. So I look for the J sign, even without complaints of instability. I test for the patella tilt for people who are kind of sitting there and their patella is just kind of flipped to the outside. I will take my fingers
lateral
and try to
tilt.
Lateral tilt.
Lateral tilt. Yes. Okay.
Yeah. Lateral tilt is kind of where it's naturally going to sit, and I try to correct it to neutral and try to overcorrect it by about 10 degrees or so. And if you can't do that, then I start thinking about possibly a tight lateral retinaculum if I'm considering surgical interventions. And so we talked about the J sign, the for the tracking, the tilt, and you said apprehension. Obviously, if you have instability, especially after acute episodes, folks will have apprehension. So you put the knee roughly into the trochlear groove, so 20, 30 degrees, and you apply that lateral force. And the ones with instability will say they don't want to, they don't like that. They might stop. You might swipe your hand away. If they let you go, then I will, for folks who are not acutely injured, you'll see a lot of translation, and they may just say that doesn't feel comfortable, and you can translate them 2-3 quadrants of the patella, so like more than 50% or even 70% of the patella width, like the patient I operated on this morning. Under anesthesia, granted, you could translate his patella 80 degrees out of the groove with no problem. So, if you see that, then you know that their patella is not stable and is not moving stably through the groove. So those are my key tests.
Rob, any others that you want to go over or that you
just
shoot?
Not specifically, more for you. Like, I mean, X-rays. What views do you like the most?
Oh, real quick before I move away from the tests, whenever I examine the patella, and I think this is very important for the therapist to remember, and I'm sure you guys know this, but the patella is just a small bone that's within our extensor mechanism. It's a sesamoid bone, and it's controlled very much so by our overall limb alignment. So things like our Q angle, our coronal plane alignment play a big role. And as we know, the hip mobility and strength matters hugely when you're dealing with those. So that's another thing that I check, especially if I have that classic patellofemoral patient, youngish female who comes in and so much pain. I will test their hips, and more often than not, you put them into full extension, their knee, and you press on their leg. Their quads will hold up fine, so their quad measurement's 5/5. But if you have them sit and you have them bring their knee up, and you're testing their iliopsoas, you're testing their hips, or you're testing their hip abductors, they usually, I can push them through with my hand without having to lean on them. And these are, normal sized individuals, not kids. So they have weak hips. I think weak hips are a huge component of patellar tracking issues, and one of the
there's some pretty good evidence about iliopsoas tightness in patellofemoral pain patients. So,
yeah, and probably in weakness of external rotators and abductors, right?
Yes, so, there's good evidence on that in the physical therapy literature also.
Yeah. So that's one of the things that I have in my prescriptions for patellofemoral pain patients is work on core, hip, pelvis. I don't tell you guys exactly what to do. I just make sure that direct attention up top and not just to the knee. And an experienced therapist will know that on their own, but it's okay if occasionally,
And actually, an experienced therapist is giving a lecture at 7 a.m. on Monday to the sports medicine orthopedic surgery fellows that anybody is welcome to come and watch and listen. Send me an email at shoulderpt@yahoo.com later tonight, and I will send you the link to the lecture that I'm giving on Monday at 7 a.m.
You gave it away. I was going to say, I wonder who that experienced therapist could be.
It's the 5 a.m. wake up that. But anyway, it's so funny how some of the younger surgeons that train different places say quad strengthening and ITB stretching, When you can foam roll that ITB and that fascia till the cows come home. You're not making plastic deformation and a change in the Ober's test unless you stretch the muscles that are attached to it. So, but it's interesting. We'll talk about that on Monday morning in detail.
Absolutely.
Back to the X-rays that Rob Shapiro is.
Yeah, sorry about that, Rob.
No good.
No, I get X-rays. I get X-rays. I mean, most of the time they get X-rays before they even come through the door into the office. But if they don't, then I will get my standard series, which includes, weight bearing, APBA views. I get a lateral view in my radiology text note to try to get as perfect of a lateral view as possible, because if you're looking for evidence of trochlear dysplasia, then you have to get a good lateral. To me, that's the number one X-ray. And then we try to get a good sunrise view. So like a Merchant's would be best, or Lord view. But
what's that going to show you?
Yeah, so I'm looking again. So patella tilt can be seen best on that view. So if you have a good view, you will see that. It's hard to see dysplasia because the trochlear dysplasia occurs in the very, very proximal trochlea, typically in the first 2, maybe 3 centimeters of the trochlea. And most of the sunrise views, the way they're done, the knee is flexed more, and you're looking down into the groove, let's say past about 40, 45 degrees of flexion. And in that position, you're going to see a groove. So I've had patients who I know for a fact have horrible dysplasia. I have MRIs, CAT scans, or I've looked at them surgically, and their sunrise views all look like they have a groove. So don't trust the sunrise views in that regard. You have to look at either advanced imaging or analyze the lateral very carefully. But I look at tilt. I look at narrowing of the joint. I look at osteophytes, arthritis, things of that.
All right, one quick, and then if somebody has like an anteverted hip, are you going to change, like surgery-wise? You actually work on. You think you'll look at the femur and try to change like an osteotomy to change it, or is it not? Where do you go? Or
it's a great question. I always look at the hip version. I'll have them lie down prone for my patellar instability, recurrent instability, or bad maltracking patients, and I'll turn their hips out, their legs out, to see how much rotation they have. Yep, and I what's it called, so I can document it in my notes?
Craig's.
Craig. Okay.
Yeah.
Craig's test, yeah. I just call it prone internal rotation. I'll sometimes take a picture. If they have asymmetry, that's pretty kind of cool. One's like this, one's like this. You're like, okay, that's the reason. Certainly, if there's asymmetry, I'm thinking of correcting them. And it's funny that you asked this, Tim. We talked about. We presented a video on derotational osteotomy combined with tibial tubercle osteotomy and all this other stuff. One of these combined procedures. We presented that at the academy, and I did it was actually like an award winner for a sports medicine video. And one of the discussions is, when do you do it? And so there's certain cutoffs, and they're a little bit debated. 30 to 35 of femoral anteversion in an adult is a suspicious number, and so I've done derotational distal femoral osteotomies for that.
Wow.
Also, if you have hip pain and hip issues, then you should consider an osteotomy, because it can correct kind of both issues with one shot. In that case, the correction should probably be done closer to the hip, which I don't really do. I would start bringing in my pediatric or trauma colleagues to help with that. I'm more kind of knee area guy, but I have done cases of correction over a nail, correction over a plate. I like the distal femoral one because you can also simultaneously correct things like valgus. So you can do a distal femoral osteotomy and correct valgus in addition to rotation. So it is something that I would consider. It's certainly not a small procedure and something that I wouldn't just jump right into out of the blue. But yeah.
I've seen patients with patellofemoral surgery that have had one surgery, a lateral release, or had a medial implication, an MPFL reconstruction, focusing tibial tubercle transfer, and then I've seen patients that have had all these at once. Can you take us through your algorithm and what makes you do one surgery, combine two, or maybe combine three, or do what this article did that we're reviewing tonight, the combination of that multiple procedures with 4 surgeries at once? What's your algorithm?
Yeah, so great question. Tons of debate in the patellofemoral world. So for maltracking, I think correcting alignment is very important, and so you got to figure out where's the alignment coming from. Some argue that you can just do the tibial tubercle osteotomy to correct the Q angle, and then there's some who believe that the malalignment really doesn't come from the position of the tibial tubercle. And this is a topic of debate, and they say you don't need to touch the tibial tubercle. You need to address other things like the trochlea or the rotation of the femur. I try to kind of elucidate where is it coming from. If I don't see significant dysplasia, if I don't see significant rotational anomalies, then I will do the classic sort of approach for patellar instability with maltracking is, reconstruct the medial soft tissues, the medial patellofemoral complex, MPFL or MQTFL, and move the tibial tubercle over. So that's what I will do for people with elevated tibial tubercle to trochlear groove distance, TTTG, and instability or maltracking. For folks who don't have instability, they only have patellofemoral pain, lateral compression pain, and they maltract, then I will do just the tibial tubercle osteotomy. And if they're not unstable, why do I need to do anything to their ligaments? When I start adding these other things, or for folks who have this really severe presentation, I had, the patient that, we did a video from, I mean, he had bilateral and we ended up doing it bilaterally. You watch this guy walk, he's in-toeing terribly. He's super, imbalanced. He lays down on his belly and his legs roll out to like 80 degrees. He had somewhat of a trochlear dysplasia, but not severe. So, and his TTTG was in the stratosphere. So we did a number of things. We derotated, and he was valgus. So we derotated and corrected the valgus of the femur. We moved this tibial tubercle over and we stabilized him with MPFL. It was a lot of surgery, tough recovery, but ultimately he was like a brand new person when that was done. So I like to do an a la carte approach. I find a problem, and if that problem can be corrected with 2 surgeries, I'll do 2 surgeries. But if I feel like it needs 3, then I'll add a third. I'm not going to hesitate and say I'm not going to do this third one because it's a big surgery and I want to give you a smaller case. You got to address everything, otherwise you're going to be back to address it at some point.
Right.
In my opinion.
Have you done many trochleoplasties in these patients?
More than most in New York, probably. Yep. I think I'm probably one of the busier trochlear. I did one this morning, actually. Funny you asked.
Wow.
More than most in New York, there's kind of camps. There's some people who are very big trochleoplasty. There's probably a very few in the United States who are trochleoplasty like zealots, right? There's a lot of these folks are in Europe, France, and David DeJour, who I had the pleasure of being in the same instructional course lecture with, and we did a radio show together at the academy this year, and it's fascinating. His father kind of came up with this whole concept of modern concept of trochleoplasty, Henri DeJour, and he's continuing his work. So it's really interesting to talk to him and speak about his experience of French, and then Germans and Swiss with the berator, the thin flap trochleoplasty, which is the way I do it. And that's Philip Schadli in Germany, and Munich is the one who's the big proponent of that. And in the United States, there's a friend of mine, Lee Pace. He was in Connecticut, but he's out in Texas now. He's part of the Andrews Institute in Texas. He's kind of a mix of pediatric and sports medicine guy. So he does a lot of these, kids with dysplasia. And so he does a ton of trochleoplasties. He himself sort of says, I probably pushed the indications a little bit, but he's a guy who believes that this is the procedure to correct. And then, most folks who do a good amount of trochleoplasty in the States are going to be like me, where they will do it, for cases where the trochlear dysplasia really jumps out at you as being pretty bad. A dome trochlea with a bump or a spur, and also where there isn't really a lot of other things going on, like maybe not a terrible amount of maltracking based on some of these measurements like TTTG. So their tubercle position is normal, their hip rotation is normal, and yet you see their patella jumping. Why is it jumping? It's jumping because it's hitting this big bump. So why dance around it? Correct the bumps. And people say, you don't need to do that. You just pull them over with the MPFL, or you just do it. You move them over by moving their tubercle. But why are you moving the tubercle if their problem is at the trochlea? It's a complex procedure. I won't lie to you, but it's not as complex as people think. It's a little bit like sculpting. The reason people don't like it, because it's not algorithmic. Once again, just like a lot of things, because you kind of whittling away. You have to elevate this thin flap of bone and cartilage if you do a thin flap trochleoplasty, and then you take your time to create a groove. And there's nobody who will tell you exactly where the groove's going to go. I'll go today with my fellow. I said, okay, where are we putting the groove? Well, how about we put it here? I mean, we didn't just randomly choose to put it there. We watched where his patella tracked. We watched where it wanted to track, and I said, Patella wants to track right here. We're going to give him a groove right here. But it's a little bit of there's more art to it, than science, and you do need to do it a bunch of times. And it's a surgery that takes time. It took us today. We did it pretty fast, and the trochleoplasty part alone took us about an hour, right?
Wow.
So people don't have the patience for that. They can bang out 2 meniscectomies in an hour with a turnover time, no problem, right? Or an ACL reconstruction. A whole ACL reconstruction. On top of that, we did the ligament reconstruction and lateral lengthening and stuff like that. So people don't have the patience for it, and I think, in all honesty, that's probably why people, one, they're afraid of the complications or the risks that can happen intraoperatively, damaging the cartilage, cracking the cartilage, and two, they don't have the patience or for this like whittling and sculpting. But I kind of enjoy it.
If you choose the right patients, the outcomes are good. This article we're going to view in a minute.
Yeah,
it shows it's pretty good outcomes.
Yep.
I had one other question before I turn it over to Rob. Are these surgeons out there still doing VMO transfers and medial implications, or not anymore?
I haven't seen a single VMO transfer reported. I've seen a patient who had a VMO transfer. I did a total knee on her. She had the old school VMO transfer plus the tubercle osteotomy. Oh my God, there was a hard exposure. I opened up her knee anteriorly and I said, "Where's the quad tendon?" The quad tendon was sitting laterally because her entire VMO just occupied everything in front of me. It was a crazy case. So yeah,
they weren't fun to rehab in the old days either. Rob, a question for Dr. Golant, Rob?
Yeah, just interesting. So you did a de jour technique. Is there other types of trochleoplasties, like you hear lateral facet elevating type stuff, or is that not big anymore, or not big at all?
That's a very astute question. So the lateral elevation is called the LB trochleoplasty. I think it was reported in the 20s. So the LB is not really done much because if you think about it, you basically are just trying to create like a lateral. So like if my patella wants to go this way, if it wants to go laterally, and I have a flat, let's say, or a dome trochlea, so instead of creating a groove for it, you still are domed. You just kind of lift it up. I can't do it with my fingers, but you're just creating you're blocking it essentially, right? So what's going to happen there? You most likely will get abnormal or excessive pressures and contact pressures, and potentially lead to arthritis. So you may reduce instability, and indeed, historically reduced instability, but it's non-anatomic. And the LB is not really used. So the two types there's basically kind of what I call the cheating trochleoplasty or pseudotrochleoplasty or a bumpectomy, approximately, just moving the bump. There's one that I'm still struggling to fully I kind of understand what it is. I think they do it at Rush. One of my colleagues, Danny Kaplan, who trained at Rush, is kind of bringing it into his practice now. He's one of our junior attendings, and he's very good. So what he does is he removes that bump and he kind of digs out, so if you have a trochlea, I'm looking from the side now, here's the femur, here's the trochlea. He kind of drops the trochlea down. He doesn't change the shape. It's still abnormally domed, but he drops it down, so reducing the size of the ramp. But it's still a ramp. It's still a ramp.
Is it called a recession wedge? Is that
exactly a recession wedge trochleoplasty? So that has some popularity because it's a little bit easier. You kind of chew out some bone from underneath, somewhat of a thick flap, and you drop it down.
Right.
What
do you do with the cartilage? Yeah, sorry. Go ahead.
No, nothing new. You leave the cartilage attached to bone.
It'll heal. I guess if it got worn down, is there anything that? Well, if
the cartilage is damaged, I usually don't do a trochleoplasty on trochlears with damaged cartilage. It's a little bit more controversial if you have patella damage, whether or not you can do like a patella cartilage restoring procedure like a MACI or an OCA and a trochleoplasty at the same time or in sequence. And, you know, a lot of people don't do that. Lead pace says that absolutely do that. Like, why would you put cartilage, fresh cartilage in the patella and leave it tracking on a very misshapen trochlea? So reshape the trochlea, treat the, so that, you know, logically makes sense too. But again, it's a lot of surgery, and I've done, I think, 1 or 2 combined cases like that. So de jure does what's called a thick flap trochleoplasty, where they elevate a relatively thick flap of the osteochondral flap, crack it in the middle, and then kind of bend it in like this. So they actually take a knife, put it in the middle of the trochlea, and they go pop. And I think that, to me, that makes me a little, with all due respect to Dr. de Jure and his father and everyone who does it, there's some great minds who do it. Just makes me feel a little like, you know, stuff starts coming up here, you know, when I put a knife on cartilage and hit it. I've done it in the lab, but even in the lab, I got so the German way, or the Swiss way, the Berater trochleoplasty is known as the thin flap. You're elevating the entire trochlea as one flap, 3 millimeters from the surface. After you elevate it like that, you actually thin it out some more. We use this guide that puts the reamer 3 millimeters under the cartilage surface. But, you know, it's very hard to reshape the bone, the flap, if it has that much bone on it. So you end up thinning it out. Then you create your groove underneath where you remove all the bump and reshape the bone. And then you manually kind of just plastically deform the trochlea into that groove. That's actually the part of the case that probably takes a really long time, not just mobilizing that whole trochlea, but reshaping it into the groove, because you're taking a layer of cartilage and bone that's been a certain shape for, you know, God knows how long, right? And that's why the older the patient, the less likely I am to do it. I think the oldest trochleoplasty I've done was in a person in their mid-30s, I want to say, 35, maybe 37. And that was a difficult flap to mobilize. The person today was 30, and that was also, we had a little bit of work to do, but it worked out well. So, you know, in an ideal world, you know, you correct it early so that the patella has a chance to get used to the new cartilage. Or the one that I've done in teenagers, they tend to be the easiest cartilage flaps to mobilize because they're still pliable.
Interesting.
And then you kind of fix it. We use little anchors and sutures to hold it in place.
So let's move on to the article now.
Sure.
We chose this article because it was an article that really kind of simulates what you do, what you've sent me. And it's a combination of tibial tubercle transfer, medial patellofemoral ligament reconstruction, a trochleoplasty, and a lateral release, all in one for our patient. All right. And they looked at good to mid long-term outcomes in these adolescent patients.
Yep.
And it gives us a glimpse into how these folks do. You know, you might not say that, you know, you don't know kind of the art of where to put that new trochlear groove, but you know what? If you can measure a positive outcome, that's worth its weight in gold. So
yeah, I was being, you know, sort of facetious. I do know where to put the trochlear groove. I'm just saying there's no like. You know, every case is a little different. You know what I mean? Yeah. Like ACL, we all know where the footprints are, right? When you do an osteotomy, you correct by a certain number of degrees.
But you don't know where the isometric point is. You know, it's kind of different for everybody. So
Excellent point. Yeah, definitely debatable. So, but yeah, so the trochlear groove again varies from person to person. I usually will always lateralize it, right? Because you're lateralizing it, that decreases your Q angle, and you can kind of, some people, and I definitely think about it. Okay, you know, this person's TTTG is, let's say, 22, right? So it's a little elevated. I want to bring it into the low numbers. I'm going to move it by 8 to 10 millimeters laterally, and that's going to normalize my TTTG because I'm moving their trochlear center to where it's supposed to be. Yeah, this article is almost exactly what we do. It does focus on adolescents, whereas our cohort, we're publishing in our cohort soon. They call it, if on like second page of the article in the introduction, they say a la carte.
A la carte. I highlighted that.
And that's exactly, you know, what we called our surgical video that we presented this year at Academy, a la carte approach for patellofemoral instability. You know, indeed, the series that compare that have multiple studies are limited, and you know, these patients with a lot of combined pathology are actually many. Now, again, a lot of surgeons who are not fans, and there's some very hardcore camps of anti-trochleoplasty surgeons, will tell you that you don't need any of these, or you don't need they will mostly say you don't need the trochleoplasty. Just do a good TTO and do a good MPFL reconstruction or medial soft tissue reconstruction. And studies show that these patients do remarkably well in terms of stability. I will tell you, though, that I think they're missing some fine points. And I think if you really dig into it, these patients who have significant dysplasia are still having abnormal contacts and abnormal tracking. They may not be unstable. I have a patient actually right now that came for like a third opinion, who was treated in a very prestigious institution by very prestigious doctors, who had a TTO, MPFL, even a coronal plane alignment correction, a distal femoral osteotomy. And the one thing that hasn't been done is a trochleoplasty, and this patient has pretty significant dysplasia. And this patient's knee has one thing, and guess what that is? She no longer feels unstable, but she feels like something catches. And when you look at her knee, it's a jumping J. She has a jumping J, even though because she's hitting that ramp, and even though her tracking is otherwise fine, when she hits the ramp, no matter how well her patellar's alignment, it's got to go somewhere, and it goes over that ramp and then drops back into the trochlea. So, you know, and her surgeon's telling her, well, you know, we try to move your, you know, tubercle. You know, I'm like, why chase the tail? Why go around in circles where there's clearly a problem that hasn't been addressed? So I think, you know, you really have to take a good look and see. And if you're one of these patients that, you know, it sounds like their criteria, again, it's not a prospective study, but, you know, I think it's two senior surgeons, and their criteria was either B or a D trochlea. That means both would have either flat or dome trochlea and a bump or a spur, which is, you know, one of the things that leads to a jump in J, potentially elevated TTTG more than 20 millimeters. I kind of no longer use that as the hard number, but it certainly makes me a little more nervous about not moving the tubercle. So these are good indications. The one thing I'll tell you about the tibial tubercle osteotomy, I think tibial tubercle osteotomy, in addition to correcting the tracking, especially the Fulkerson modification, has a particular benefit for people with pain rather than just instability, right?
Yes.
Because you don't just medialize, you can anteriorize. Now that you cannot do with a trochleoplasty. So if I have a patient who has more pain and less instability, right, and they don't have that jumping J, let's say they have a flattish trochlea or even a slightly domed trochlea, but their main complaint is pain and they don't feel terribly unstable, then I'm going to err towards the tibial tubercle osteotomy, and I do the AMZ, the anterior medialization, which is the Fulkerson modification to the classic French, you know, Elmsley Trolot, or not just French, British Elmsley Trolot variation. So I think if you need to do an anteriorization, that's one of the reasons to sway towards TTO. And the other one is if you have a big patella alta. If you have significant alta, again, you can't really correct that without distalizing. Now, you know, how much alta we need to worry about is debatable. Yeah, like Caton Deschamps over 1.3 is where I start thinking about it. But usually, you know, if it's borderline, you don't need to go crazy moving the tubercle. But if it's like a 1.5 Caton Deschamps, if their patella is sitting in the stratosphere, then you probably need to get it down a bit.
I suggested this paper because this paper, there's very, very few reported procedures in the literature that have three or greater procedures in one patellofemoral surgical case. And this is a pretty large sample of 21 patients. and they had very, very good results on at a long-term follow-up of 5 years, which is very unusual. Okay, and you can see that that in table 3, all the radiographic information improved. Okay, and then on table 2, you can see that all the subjective pre to post data improved also, you know, in terms of patellofemoral pain, dislocation, apprehension, and they had we used the Kujala score also for patellofemoral outcome, and is that what you guys use also? It's pretty patellofemoral specific score.
Kujala, and then you know, just promise for the knee, but you can also use Kus. It's a little more involved, but I like Kujala. I like Kujala for the anterior knee for sure.
Yeah. So that's why we chose this paper for the audience, and there was great results.
Now the interesting thing I'm trying to see, and I looked at the study before, but I can't remember now. Did they report on any complications or any like return to the OR?
You know,
I didn't see any mention of that.
Not.
So that's interesting.
I did not see it either.
Yeah. So they said that there was no dislocation, pain, or apprehension. You know, no longer present post-op, statistical improvement. So I think that's probably one of the things that I would have critiqued if I were to review the study. You know, if you didn't have any, great, say you didn't have any. But I kind of doubt it. I'll tell you one thing that's pretty common with the trochleoplasty, because it is a procedure that, as you can imagine, produces a good amount of intra-articular bleeding, right? So you're elevating this flap, you're digging bone. It's almost like a total knee, right? Or patellofemoral arthroplasty. So guess what they get? They get arthrofibrosis and stiffness. So we, in our report that we just submitted an abstract, and we're going to be publishing the data we had. That was the most common complication, was return to the OR for an MUA and lysis of adhesions. Cool thing is I kind of like coming back to look at them, because it gives me, it makes me sleep better at night now, because I look at that trochlea, and it's usually at around, you know, somewhere in the 6 to 12 week range where I'm back in the OR with them. The sutures that I put directly on the surface of the cartilage, so we use an anchor at the bottom of the groove, at the lowest aspect of the trochleoplasty, and we put a combination of sutures, and then we take them up through the groove and then secure them with another knotless anchor, and we do it like in a kind of 3-way shape to hold the flap down. Those sutures, I use Vicryl sutures. They're pretty much gone by about 6 weeks. You kind of see a little remnant of a little synovialization. So there's no more suture irritation, because at the time of surgery, you got this kind of, in Europe, they have something called Vicryl tape, which we don't have in the States. So they put tape, so it's a little smoother. Here, I just use strands of Vicryl suture, which is dissolvable. But when I move my patella, I'm like, oh my God, it's like kind of grinding on that tape. What's going to happen? Or on those sutures, it's gone, and the movement is perfectly smooth. The cartilage, in every single case that I've seen, has looked great. No cases of, you know, osteochondral flap necrosis or any issues like that. Sure. And I think long-term data on trochleoplasty has certainly been published, and by DeJour, he has some radiographic evidence of arthritis, but clinically patients have by and large done well.
If you send one of our patients one of these cases that you just described, when do you expect them? When should you expect them to get full range of motion, flexion, full extension right away, probably, but full flexion? When do you expect them to get it? And so, do we address patella mobility at all?
100%. So I actually, that's why I bring it up, that the arthrofibrosis is one of the complications. I think it's super important for you guys to work on it, especially if I do, like the case today, I did it without a tibial tubercle osteotomy. To me, tibial tubercle osteotomy is more restrictive than a trochleoplasty. Right. Because what's there to restrict, right? I did a trochleoplasty and MPFL reconstruction, lateral retinacular lengthening. Patient will be locked in a knee brace. They're allowed to weight bear right away, locked in a knee brace. Yep. I'm allowing them to range pretty much to 90 degrees right away. And the only reason it's 90 degrees because people don't like stretching past 90 degrees. Is he going to range to 90 degrees? Absolutely not, right? He's going to be in pain. But I prefer for that range to be passive in the beginning so that he's not firing his muscles and compressing, you know, so he's not stressing my medial reconstruction, and 2, so he's not, creating excessive contact pressures in the joint. But I think in terms of return to range of motion, I would like them by 2 months to have full range of motion, by 3 certainly. So if I'm seeing no, if I'm not getting past 90 by 6 to 8 weeks, I'm taking them back to the OR.
Excellent. And then when will you let this athlete return to play and then return to previous level of competition?
Yeah, so just like when you're treating a fracture, right, you want the bone to heal to bone. So here you want the cartilage, osteochondroplasia flap to heal. So 3 to 4 months, if they're feeling good, I'm going to let them jog, right? If they're feeling really good, if there's no instability, maybe using a J brace or something. 4 to 5 months, I'm going to have them start, their sports-specific training, maybe some pivoting, some faster running, and by 6 months, if they're feeling good, I'll let them go. I treat it like a MPFL reconstruction. I don't really, as long as the trochleoplasty is healing well, I don't see the need to hold them back any longer than MQTFL or MPFL reconstruction. Maybe with the exception of like explosive deep squat jumping. So if they're like a CrossFitter type person, I might have them hold off on that because they're really compressing that trochlear groove. So I might just give it a little more love. TLC.
We have a few minutes, Dr. Golant. Can we take a couple questions if we have them from the audience, and then we'll let you go?
Rock and roll.
Rob, can you help me out there? Donis?
Yeah, I actually have a question myself for the arthrofibrosis. Are there any mitigating strategies that you would recommend? Like you mentioned, like earlier range of motion.
Yeah, you're my mitigating strategy, Don. I'm serious. A good communication between because people are scared. Honestly, just the same way that the docs have misconceptions and lack of knowledge about trochleoplasty. So do therapists, right? I mean, how many therapists have even heard the word trochleoplasty?
I've maybe seen 5 in my lifetime.
Right, and you are one of these very experienced, been around, been there, seen that kind of guy, and so people don't know. There's not like a known protocol. Every surgeon has their own protocol. So I encourage you, if you're a therapist and you have a trochleoplasty come in, call up the surgeon, send them an email, say, hey, I haven't seen too many of these. How do you like to rehab them? What's your protocol? Is it most like a TTO? Is it most like an MPFL? When like Tim said, when do you want them to have full range of motion? When do you want them to hit 90? When do you want them to start doing active? So really, I think it's the communication between us, and that sometimes gives me pause because I'll just, usually I have a specific protocol for trochleoplasty, but sometimes I'll have like something unusual, like posterior shoulder instability rather than anterior, and my PA will attach the anterior instability protocol, and the therapist called me. He's like, "Hey, are you sure?" I'm like, "Oh, shoot, you're right. Let's rework this one." So yeah, communication. That is really if you're asking in terms of pharmacologic or injection, you could consider something like hyaluronic acid injections. I don't think you need to go crazy with PRP or BMAC or anything. Certainly, I would not do steroids into the joint because these are typically young people with good, healthy cartilage, and I don't love putting steroids on good, healthy cartilage. I think getting their pain under control. I don't hesitate to use NSAIDs. There was a lot of conversation about whether NSAIDs prevent healing. There's been no evidence of that in sports medicine literature. We've seen with rotator cuff tears, patients taking NSAIDs, and it just helps decrease the rate of opioid use and doesn't change outcomes. So I think it'll be the same. So all my patients with with just about all surgeries, they get, around the clock, first 5 to 7 days, unless there's contraindication, using NSAIDs to kind of keep the inflammation at bay so they can start working through with their therapy.
So you hear about like, do you medial guides, and I hadn't seen a lot of these, but one doc said, I still want superior guides of the patella. Does that make a difference, or would you agree or not, or just
superior glide with just like up and down the groove?
Yeah, up the groove, because he said too much compression on that. Medial lateral, he was fine. Well, lateral, he was fine. But
I don't see why not, right? The patella tendon is not the stretchiest of substances, so I don't know how much superiorly he's going to be able to glide it, right? Like once you bend the knee, 20, 30 degrees, right? Now you have your patella and your quad tendon on a little bit of a stretch, right? You can move it up and down. So I guess you kind of move in the retinaculum up and down rather than side to side. So you're not stressing potentially your retinacular. I do a lateral retinacular lengthening. I don't do a full release if I can avoid it. So yes, you're not stressing your lengthening and you're not stressing your medial reconstruction. I think that sounds pretty reasonable, I guess. Yeah, if you have a certain excursion there. Sounds interesting. Never heard of it.
Maybe he made that up. Who knows? That's what he wrote. Medial only, no superior. So that was it wasn't.
People. It's about as one of my martial arts trainers would say, "Fake it till you make it." If you speak with confidence, people will
believe you.
Will believe you.
Cool. Yeah, I don't think I see any questions. Donis, anything? I don't see anything.
No.
Well, Dr. Golant, thank you for joining us tonight. I really
thank you.
Thank you, Tim. Thank you, Rob and Donis and everyone else. I appreciate you putting me on this. This is fun.
Thought we had a good time. All right.